Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree, Chappell, co-editor-in-chief and anchor today here on Top Med Talk. I'm joined by my co-host, Saul Aronson. Hello, Saul. How are you?
Cool guy, Saul Aronson.
I usually introduce him as cool guy.
Yeah.
It's true.
Hi, Desiree. Good to be here.
It's good to be here, Saul. We missed you last year, but glad to have you back for some of these great conversations we're going to have over the weekend.
Good to be here.
Yeah, it's good. So over the last several years here at Top Med Talk at the meeting Anesthesiology, we've been having conversations about payment models and kind of how things roll in the world of anesthesiology and how we are paid. And so it is wonderful and my pleasure to introduce one of our former guests and a Top Med Talk favorite, I do have to say, Dr. Gall, here on Top Med Talk, Dr. Jonathan Gall. Thank you so much for coming back and sitting down with us.
Thank you for having me. I'm excited to be here again.
Yeah, that's great. Now, joining us today as well, last year I think we had Dr. Connolly. We have Dr. Gordon Morewood. Dr. Morewood, thank you so much for joining us.
Thanks for having me.
Gordon, great. All right, so for our listeners, I'd love to hear a little bit more about yourself, where you currently practice, and your role within the American Society of Anesthesiologists.
Sure. So I am currently the vice chair for the Committee on Economics for the American Society of Anesthesiologists, and my clinical role is, since July, I've been serving as the chief of anesthesia for the Piedmont healthcare system in Georgia.
Oh, nice. Very, very good. And Dr. Gall, how about you, Jonathan?
So I am the chair of the ASA Committee on Economics, and I am director from New York to the ASA board. And I'm a professor of anesthesiology at the Icahn School of Medicine at Mount Sinai in New York City, and president of Greater New York Anesthesia Services.
Yeah, both of you guys are very busy. That's what I heard
Little
about all
bit.
that.
Yes.
Well, and especially when it comes to the economics of anesthesiology and how we're paid. So, Jonathan, I think I ask you this every time. I think it would be good to level set and kind of, for our listeners, give them a better idea of what the landscape looks like in the U.S., because it's very different from, if someone's listening in the U.K. or Australia. So why don't you set the stage for us a bit?
Sure, yeah. So the way that anesthesiologists and anesthesia practices get paid for the care that they do is it depends on certain different types of codes. So we have CPT codes, current procedural terminology codes, and we utilize those anesthesia for certain surgical types of codes. So there's about 6,000 or so surgical CPT codes. There's about 275 anesthesia for those different surgery type of CPT codes. And so when we provide a service, we find the anesthesia CPT code that crosswalks over to that surgical type of case. It's got base units plus time units, depending on how long the case winds up being. There's other sorts of procedures we might do, like an arterial line or a central line or a post-op nerve block, that we add on to those as well. And then those all come together with a conversion factor that we multiply by all the different units. There's two different types of conversion factors, whether it's the non-time-based codes versus the time-based ones. And then we would submit that to the payer. Now, that's where the landscape gets even much more different, is that we have many different payers here in America.
Yeah.
So we have our governmental payer mix, which is Medicare. So we have the Center for Medicare and Medicaid Services. Medicare is nationwide, and then there's Medicaid, which is for low-income individuals in each state. And each state has a different way of kind of scripting up how Medicaid gets paid. And then we also have private payers. So some of the more popular names and bigger ones for those are United Healthcare, Blue Cross Blue Shield, Aetna, Cigna. Those are some of the bigger ones. And then even within the governmental payer mix, we can have Medicare Advantage plans, where basically Medicare has signed over the benefits for a Medicare beneficiary over to United, and then United or Blue Cross Blue Shield or whatever will be the benefit manager for those different patients. And then the same thing happens on Medicaid as well, where we have managed Medicaid plans too. So there can be genuine fee-for-service with Medicare, Medicaid, and those private payers, plus the managed Medicare and the managed Medicaid versions too.
Sounds so simple.
Yeah, no, that took me about 12 seconds, right?
And self-pay or prompt pay or no pay.
Yeah.
That's very true. Yeah. So, Gordon, I wanted to ask this question because we all travel a lot internationally, and I always get the question of, well, like, how are you actually paid? Is it, because there are some countries where, and I know here in the U.S., it's the individual is billing on their own behalf and billing, and they receive that money. Or there are people we're organized in different groups, or you're part of an institution. Can you walk us through that just a little bit more?
You mean from the individual standpoint?
Yeah.
Receiving the health care?
Yeah.
Yeah, so for the vast majority of Americans, they don't touch the bills at all. The model for both Medicare, Medicaid, and our private insurers is that when the patient receives a service, the bill is sent directly to the insurer. The insurer will send statements to the individuals but they don't pass the money through the individuals themselves. There are certain exceptions to that around Medicare for physicians who have opted out, things like that that are settled. But that's how it works for most people, which is an interesting system because it kind of divorces the value of the service that the individual is receiving from the payment for the service. And that's one of the things that I think really produces a struggle in the modern medical system here in the United States is that, you know, for most things, you walk up to the counter in the corner store and you want a pack of gum and it says $2. You think, that's worth $2. I'm going to pay $2. You walk into your local hospital and you want exceptional care to get your gallbladder out. You may really value that, but the person who then pays the bill isn't the same person receiving the service. So that's one of our real challenges.
Yeah, and then whenever it's the anesthesiologist getting paid, that is an even different type of model because we're organized in different ways, right?
Correct. So you have, in this country, there's been an interesting evolution over the last 20 years or so. When I graduated from my training back in the 90s, most people were in some sort of private group practice, except for the institutionally employed academic centers. We went through a consolidation phase where national companies became very popular. That then those national companies were consolidated by private equity, so you had most physicians working for these large national conglomerates, and now we're sort of seeing the beginnings of a reversal of that trend where most institutions are realizing, no, we want to employ our anesthesiologists directly, but there are very few anesthesiologists still in private practice by themselves.
Yeah, we'll have another conversation about workforce and get into that. But that changes the way we negotiate with our payers, right, is how we're organized. So there are lots of different models out there of payment. Jonathan, you mentioned like a fee for service, and it's just, you know, you do this and you get paid for that. But there are other models out there, right?
Right, so there's these alternative payment models as well. And so that's more of a, can be at the individual episode or population-based payment model structure. So at the individual level, it's providers take care of different patients, and then they submit how well they do on certain quality measures or other sorts of measures. And with Medicare, with our national governmental payer, that's called MIPS, which is another acronym, Merit-Based Incentive Payment System. And so for that's on the individual level. They also have bundles for episodes of care where you have a target price of all the different things in that episode of care. If they come for a certain type of surgery, like a joint replacement, there's the surgeon's fees, the anesthesiologist fees, physical therapy, hospital, the implants, all those sorts of things. They all get bundled together, and you have a target price for that. And then there's episodes, population-based, which is more of an accountable care organization, which manages a whole population of patients. So for me in New York City, we have a solid 500,000 patients that are attributed to our health system, and they're attributed from different payers. And so for one individual payer, say like Medicare, maybe there's about 30,000 patients in the New York City area that are attributed to our accountable care organization, and we manage all of their care, not just the episodes, but the entire annual expenditures for their care. And they're all wind up getting attributed to us. And so you can have bonuses structured into your arrangements with any payer, with Medicare, with commercial, private payers, et cetera, to give some additional bonus payments on top of that, as they like to call it. I like to think of it more of like they can pay us this much, but they're going to penalize us if we don't get there.
Yeah.
So it depends on your perspective on that.
And can you speak a little bit about the trend? We've been talking about the coming, if you will, value-based tsunami relative to fee-for-service. Where are we with respect to that relationship today?
You know, I feel like we're actually in a stagnant area for it. It's not as sexy as it used to be. So CMS has been trying to come up with some more, engagement on these different models, because there's still some of the same stuff. So they've got a new model called TEAM, which is another acronym, and I haven't memorized that
It's
one
okay.
yet.
We'll put it in the notes.
It's essentially bundles all over again, and they just
Yes.
have a couple new measures on that, and they want to try and encourage some gain sharing because the answer is money, no matter the question, and so they want to try and have people be engaged with it more by dangling some more money in front of it. But the reality of it is that the amount of money that they're dangling there is just not enough to get proper uptake from it.
And how does anesthesiology come to the table for the distribution, if you will, those fixed bundles?
So that, go ahead.
Yeah, I was going to say, that's the issue. That's the complexity. And that's one of the reasons that I think so many of the APM models have struggled to get up and off the ground. I mean, they all have the common theme in that the payers have figured out that they no longer want to pay for process.
Yeah.
Fee-for-service payments is paying for the process. So you pay for every time you touch the patient, every time you do an x-ray, et cetera, et cetera. But what that stifles is innovation. People can't innovate around how they're going to care for patients because you're tied to the process. Unless you adhere to the process, you don't get paid. So alternative payment models ultimately are saying, here's the money, you guys figure it out. But making that transition from the fee-for-service to the alternative payment models, that's where they're having trouble making it understandable to individuals. And anesthesiology is a great example. I mean, we sit at the center of so much extraordinarily expensive care, but how, and we definitely can affect the amount of resources that are utilized to deliver that care, but how do you recognize that in an APM? And when you try and do this centrally in a system as complex as the U.S. healthcare system, it's a real challenge for the payers to figure out how to do that.
Yeah, and we could get into a whole conversation about the value of what we have to bring to the table and how improving quality. I mean, that's what the motivation of a lot of this is too. Is hopefully that by doing this and bringing together the way that we're paid, will hopefully improve and incentivize good high quality care.
Yeah, because the dirty little secret that I 100% believe is that better quality care is actually cheaper care. Like people talk about we want to improve quality, but actually what you're saying is we want to stop paying for all these expensive complications.
The avoidable costs. But how do we declare our role in delivering that quality?
I think part of it is, I think there's a number of different aspects to it, but it boils down to making sure that you have the right patients getting the right care at the right time. So there are lots of patients still getting into our healthcare system undergoing procedures because we pay fee for service, we pay for the process, so they undergo the process, but the outcomes aren't great. You know, these frail patients whose risks are extraordinary and yet
not optimized.
Not optimized.
Yeah.
You know, so anesthesiologists as gatekeepers, as part of, you know, if you had
perioperative process.
Perioperative process. If you had sort of like a tumor board approach to really high intensity invasive procedures, and you had, you know, surgeons, internists, anesthesiologists, nurses all sitting around the table and saying, okay, is this patient really who we're going to spend $50,000 on this process for? You know, is this the right patient? We could weed out a lot of patients that really don't benefit from the care that we deliver them. So there's that's, you know, as gatekeepers, as helping to make decisions.
And make sure modifiable comorbid conditions are optimized before we, you know, if a patient needs surgery, they need surgery. But you shouldn't have surgery until you're ready for surgery. You don't land a plane until the wheels are down.
Exactly, right. So, you know, do we have the right patients going for the surgery? If we have the right patients going for the surgery, are they ready for the surgery? And then once they're in the surgery, are we really putting the right resources in place for each individual patient? So I think there's lots of value added there that physicians, that anesthesiologists can bring to the process.
Yeah, specifically.
Desiree, I'm going to go into the, you know, the zone of fee-for-service because it's still a big corpus of our reality, and CMS reevaluation of the, if you will, unit value for anesthesia, and how does that disproportionately harm us? Ouch! Ouch!
Wow, Paul, you're just diving right in. You ready for this?
Well, we need
somebody got the beeper button. Right?
Yeah.
Well, but we need to make that clear.
Well, it depends on the angle that you're coming from. So, like right now, they've come out with there's a conversion factor from CMS for regular non-time-based things like surgeries and primary care visits, E&M visits, evaluation management services, and then there's a separate one altogether for anesthesia. And we have our own separate conversion factor for that that gets paid off of our base plus time. This coming year, there's now going to be 2 conversion factors for each one of those. And that it's going to be whether you the have and have-nots, those that are in a qualified advanced alternative payment model and those that are not. Now, the difference in those conversion factors is really not much. It's literally 10 cents. So, you know, even if you did the 10-unit case, you got an extra $1. It's really not that much. The average case is usually about 12 units nationwide. So you can get an extra $1.20 per case with Medicare. Now, that's not really cascading with all other sorts of payers out there, such as Medicaid or even the private payers, whatever. But that's where they're starting to put a difference percentage-based wise between those who are in a qualified advanced APM and those who are not. And this year it's only 10 cents, but that gap is just going to get wider and wider as years go on because, like I said, it's percentage-based. So next year that percentage gets up. Maybe it's more like 12 cents next year. The year after that it's more like 14 or 15 cents, et cetera. So they're continuing to try and, you know, use money, again, to try and, you know, influence behavior then.
And people have to understand how, you know, listeners should understand how that conversion factor is derived.
Yeah.
You know, there's the cost of providing the care, which would be one way to calculate the conversion factor, and everybody knows that the labor costs for anesthesia care in the United States have just gone up and up and up. So that would be one way to derive the conversion factor. The other way to derive it would be, well, what's the value delivered to the patient? You know, go back to the chewing gum example. What are patients willing to pay for excellent anesthesia care? Unfortunately, neither of those apply.
Right.
The way the conversion factor is derived is, you know, there's a Part B Medicare pool of money available each year, which is determined, which comes out of the general revenue of the federal government. They figure out, they project how many ASA units they think are going to be claimed in the coming year. They take the pool, they divide it by the number of units, and they say that's your conversion factor. So it has nothing to do with either the value or the cost of care. And obviously that system is unsustainable, and that's why we're seeing just a gradual erosion of the professional fees supporting the care that we provide, and we're having to find other sources of funding.
Yeah.
And what's further bogus about that is that the other areas of Medicare, how the hospital gets paid, how even the private payers, when they manage the, do Medicare Advantage and stuff, how skilled nursing facilities, all other areas within healthcare, they do get to utilize the cost of providing the care and the prices that patients will pay. However, when it comes to professional fees for the physicians and other advanced practice providers, whatever, we don't get to have that sort of negotiation.
Yeah, and it's really hard for many of us because what we bill does not necessarily, or what's billed on our behalf does not necessarily cover always the care that we're delivering, and so we have to work. And I think we had conversations about this as working with our hospital partners to ensure that we can cover the cost of care for us because we don't get to bill for those. So very complex, lots of different angles to this. I think what I would love to try and understand is that, I think you mentioned it already, is that there's been an erosion over the years. And I think last time we talked about the percentage cuts that we were seeing in CMS and how that becomes a battle for us every single year. Can you talk to us a little bit more about that?
So because of these budgetary restrictions, that although more CPT codes and more CPT RVUs are being submitted each year, there's only a certain number of dollars that can be paid out. And so to account for that, they have to drop the dollar amount that each unit is worth in order to try and stay budget neutral on that. And so we're experiencing that again this year. We did a strong amount of lobbying and advocacy this past year to try and come up with what Congress was calling a doc fix. We wanted to come up with something even more clever than that, but they wanted to call it the doc fix. They dumbed it down to a quick quip like that. But nonetheless, we wanted to try and tie it to an inflation adjustment. And so many of the other areas within Medicare all basically go up even faster than inflation. So our consumer price index is our main inflation index here in America, and so that has gone up a solid 3 to 4% each year. The adjustments that other areas of Medicare, such as hospital payments, ambulatory surgery center payments, skilled nursing facilities, et cetera, have gone up even faster than that, more like 4 to 5% each year, whereas physician payments have remained relatively flat for that entire time over the last 20 years or so. And so the index that Medicare uses is called the MEI, the Medicare Economic Index, which is their inflation adjuster for healthcare costs. And that's more in like the 2.5 to 3.5% range. And so we were looking for a doc fix that would tie the Medicare physician fee schedule to go up in cahoots with the MEI each year. We came very close. And then even when we were getting very close, they were still going to be like, okay, well, we'll tie it to the MEI, but you won't get all of it. You'll get like 75% of the MEI in the first year, and then you'll get more like 10% of it moving forward. So 75% of, say, like 3% is more like, what is that, 2.5% going up? And then 10% of it every year after that is only like 0.2%, 0.3%, whatever. So it was really not all that we wanted. Yeah. But we're still making progress, and they realized that an inflation adjustment would be finally appropriate instead of these cuts year after year after year. However, there's still some work to go because it was not finally passed.
Yeah. So we have this bundle of patients or patient population that is paid by CMS in whatever model and however that is, but we have a large portion of patients that have private insurance. How does what CMS does impact how a private again, might get the bleep button out
get the beeper out.
And what have we done about it?
I was just going to say, and that was going to be my next question.
Right. So the commercial payers used to be our friends, or at least they were the saving grace for the specialty. We used to have what was called a 33% problem, where Medicare paid us, literally a third of what the average commercial payer would pay us, and that's what kept most practices solvent. It was the fact that they actually lost money caring for Medicare patients, but they made it up on their commercial payments. We now have a 25% problem, so you can look at that as either good news or bad news. The Medicare has now fallen to 25% of the commercial payer rates, but what we're starting to see is that those commercial rates are not going to keep going in that direction, and they have become very aggressive in recent years about negotiating down rates, using some of the federal legislation like the No Surprises Act to try and erode rates even further, and then just frankly arbitrarily denying payment for a number of the modifiers that we use to indicate patient complexity that required more resources. So the insurers have made it pretty clear that they are just going to stop paying for the care that we are providing. And that's the disappointing part, is oftentimes we have no choice. We're going to provide the care. It's not like we can look at the price of what they're going to give us and say, we're going to do this or we're not going to do this. We look after the patient. We do the appropriate thing when they roll through the door. We then submit the bill and they say, yeah, but this time your payments have gone down by 20%.
Oh, no. Yeah. If we're not going to choose not to put an A-line in because we don't get paid for that. So, and the complexity of patients is ever increasing. I mean, I think you said it, more complex patient, more complex surgeries that we're doing. And so it is a bit of a quandary. So, what is the ASA doing?
Oh, God.
Well, some things are confidential and some things.
Oh, of course.
Public,
okay, what can you talk about?
We're certainly not just laying down on this. So
yeah, of course.
Last year, I believe it was Aetna who came up with like a kind of a large policy where they were no longer going to pay for physical status modifiers. Right. Now, the ASA physical status modifiers is a classification system we use to base, perioperative risk. Yeah. So the sicker you are, the more likely you are to have a morbidity mortality associated with it. And so we have ASA 1, 2, 3, 4, 5, and then it kind of goes up in like complexity there. And so for an ASA 1 or 2, there is no extra payment, requested for that. For an ASA 3, we ask for an extra unit. ASA 4, 2 extra units, and so on. And so many of the private payers have been reimbursing us based off of that stuff on our claims. And it was just last year Aetna started with saying that they were no longer going to acknowledge those on their claims. Just one-sided policy, and they literally said it was about the money. It wasn't about the patient care. United Healthcare has now piggybacked on that as well, and as of October 1st is no longer paying for those physical status modifiers, and they've added on as well qualifying circumstances. So those are taking care of patients of extreme age, those less than 1 or over the age of 70, taking care of emergency patients, deliberate hypotension, hypothermia, those qualifying circumstances where there's obviously a lot of extra work that goes into higher level care in those sorts of circumstances. And so it's the rationale of if you're taking care of a patient for a hernia operation, if they're a regular healthy ASA1 patient, that's a nice routine case. If they're a rather sick end-stage renal disease, all this, diabetes, hypertension, aortic stenosis, whatever, that's more of an ASA4. Yes, that is a much more complex patient to take care of, and yes, I should be getting paid for that extra higher level of care. And CMS and other payers have already started to acknowledge that this in other sorts of specialties, like primary care, they came up with a new modifier a couple years ago called G2211, which literally is about when a patient comes into a primary care office and they have a higher level of complexity for their evaluation and management, they add this modifier on there and they get higher payment for it. Surgeons are also trying to push some codes that when they take care of more complex patients, maybe more obese patients, things like that, that they would also get paid more. And so we already have those codes. We had been getting paid by them from the private payers, and so we're looking to pursue ensuring that not only the private payers go back to paying those, but that we also start getting it from CMS as well.
And how you tackle that, listeners need to understand that in the United States, insurance is regulated on a state-by-state basis. Mm-hmm. And so the state insurance regulators actually have a fair bit of control over what the insurance companies in their states do. And that has been a large part of the ASA tactic, is to go state by state, working with the members that are in that state, working with the state legislators, working with the insurance regulators, and saying you are the individuals who are, you are the only individuals who can hold the insurance companies to account, so please do your job. They've collected money from their customers to provide health care, and then they're just simply keeping it in their coffers, having it flow to the bottom line in record profits, and are not paying for the patient care that their customers have paid for. You need to do something about that. And so far, we've had some reasonable successes.
I was going to say, what are some of the wins you had? Oh, go ahead, Tom.
No, and the unintended consequences of those gaps are just bad for patient care and access to care. The No Surprise Act that obviously is state by state debate it and negotiate it. What progresses have happened that you can share with us?
Well, so so many states do have their own individual laws about surprise billing.
And
surprise
sorry,
medical
I hate
billing.
to interrupt you. Can you just tell us a little bit more about what that means? Because I don't think everyone understands what No Surprises Act was.
Sure. Yeah. So there was a business practice where, kind of from both sides, where if you were out of network, you need to like make a contract between a practice and a private payer to be in network and agree on rates. And if you were out of network, then and you took care of one of their patients, you would send the bill to the patient, and get reimbursement that way. Patients would find that as a surprise. That they, I thought that my surgeon was in network, my hospital was in network. I didn't realize that the anesthesiologist was out of network. That's a surprise to me. It'd be considered a surprise medical bill. And so there was a push to try and limit that sort of surprise for patients, and it was to hold the patients harmless, right? So, the monies are obviously out there with the payers and stuff, so, have them, be the ones who do the payment. So they came up with, and many states had already come up with laws for their, but not all, 50 of them. Mm-hmm. And so the federal government came up with the No Surprises Act, which was a clever way of saying that they wanted to try and prevent there from being surprise medical bills sent to patients from now on. That was enacted it went live January of 2022. Mm-hmm. And the implementation was just botched from the start.
Disaster.
And so there's been multiple different areas where it seemed as though the payers had the advantage from the way that it was being implemented, that they were able to slow play the entire independent dispute resolution process. Even if providers would win the IDR process, the payers might not actually pay right away. Or not pay at all, and say they go through an appeal process, but there is no appeal process in the legislation. So other ways of just gaming the system. And as a result, there's been multiple different lawsuits filed related to the implementation of that legislation. Most of them filed here in Texas, where we are right now in San Antonio. So the Texas Medical Association has been the one who's led the charge on that, and then the American Society of Anesthesiologists has filed amicus briefs in support of each one of those. And fortunately, we won each one of them. They've gone now through 4 different types of, they call it TMA 1, 2, 3, 4, whatever. And they're about different areas within the implementation that were just botched by the federal government and needed to try and level the playing field between the providers and the payers.
Yeah.
And it's important to note that when people actually manage to get through the process of the NSA appeals, physicians are winning. Anesthesiologists are doing very, very well. They're actually winning the majority of the cases. They're getting the payments that they expect. So the process can work. It's not necessarily a bad concept, and I think the original legislation was actually well written with input from the ASA at the national level. But the problem has been the implementation and the rule writing, and that's where, this is where the advocacy plug comes in. If you're an ASA member and you're listening to this podcast, or if you're not an ASA member and you're listening to this podcast, understand that the ASA is deeply involved with each of these processes. They're fighting in the courts every single step of the way, trying to make sure that you have a fair shake under the NSA.
Yeah, that's great.
And the IDR.
And the IDR process, yeah. Is there a place that people can find out more about the IDR process or any more about advocacy?
So yeah, on our ASA website,
Yes.
and we have a ton of resources. Myself and Gordon have probably authored quite almost all of them. But so there's a section within managing your practice on the ASA website that has an area for it's under surprise medical bills, and it's basically a kind of a walkthrough, the infographics, frequently asked questions, other sorts of descriptions of how to understand the different areas of the process of the IDR process and appeals and things of that sort, all the different lawsuits that have been filed and how we've been in support of those and everything. And so there's almost too many resources. It would take you a couple weeks to get through all of them, but it's all there. With the audience being anesthesia practices and especially anesthesia practice leaders who need to be dealing with this while others are providing all the clinical care.
Yeah. So, go ahead.
I was just going to say, curious. I served on the ASA Economic Committee for 12 years, way back in the days when I was tall.
You get nostalgia right now?
Yeah, exactly. And I always remember, that, in addition to the guts of the work that we would do, there was always a skunk works group out in the corner trying to figure out how to change, if you will, the anesthesia payment methodology to be more in line with the language of the rest of the world. Never figured it out. Should we even try anymore?
Yes.
Yeah.
Is the short answer to that question.
Let me tee Gordon up for this one a little bit more. So on the Committee on Economics, we do have spent a long while of focusing quite a bit on the government payer mix, mostly on Medicare and all the different ways that they are navigating the whole payment system. We've made a concerted effort over the last 4 or 5 years to really expand and show more focus on the rest of the payer mix. We've got work groups now on Medicaid. We've got the No Surprises Act work group. We're working through alternative payment models, and we now even have one about healthcare payment litigation, payment for anesthesia innovation. We want to have a seat at the table for ASA members in those sorts of circumstances. But there is an area called like an obligatory area of the Committee on Economics that's also some of the grunt work stuff. So we've got our relative value guide and our ASA crosswalk, and we have to go over all the CPT codes. But then we also have our RUC and CPT teams. So CPT team, we've already kind of defined that one, the current procedural
I was told
terminology one.
that we used to say CPT is chess and RUC is rugby.
Well, RUC is what Gordon is on. Gordon is on our RUC team. You want to describe whether that's a good description?
Yeah, I think that's a pretty apt description. So the RUC is the RUC is the AMA committee where all the specialties get together and essentially assign the different RVU values or ASA weightings to each of the different CPT codes that we use to bill for our services. But understand that only has so much influence. It doesn't change the bucket of money. All you're doing is deciding how many slices it gets cut into. So that has a limited effect. But in terms of more long-term strategy like what you're discussing, so one of the major initiatives of the ASA over recent years has been the establishment of the Center for Anesthesia and Perioperative Economics, which is ultimately going to become an independent think tank. And their express purpose for existing is to develop 3 to 5 year economic strategy plans that will help influence policy, will help influence payment schemes, will introduce tools to individual practice to be able to navigate this environment that we're in now. And one of the aspects that they're looking at now is rationalizing some of the Medicare regulations and language around anesthesia because so many of the private payers now are defaulting to Medicare regulations and saying, well, we're just going to do what Medicare does. Yeah. For so long, I think the specialty kind of ignored the not ignored, but, put the Medicare regulations to the side because they were such a lousy payer anyways. We didn't really worry too much about it. We focused on our private payers. Now that the private payers have jumped on the Medicare bandwagon, there is a burning impetus to solve some of the inconsistencies and irrationalities in the Medicare policies. And so one of the things that CAPE is focusing on as their initial project is trying to sort out that Medicare language.
And I would also hope, guess, to offer quantitative metrics to establish our role in contributing to the value proposition.
That's a much bigger project, but yes, that would be, for example, that would be an example of a 3 to 5 year project that CAPE would take on.
It's true. So that is a long-term goal, right? So we've got 3 different work groups right now as part of CAPE to really trying to incubate these ideas and come up with we've got some early low-hanging fruit wins. We've got some 3 years down the road, 5 years down the road, and I think something like that would be more of a 3 or 5 year down the road where I believe we could probably use like a value-based care one, which is more aiming towards facility agreements on financial support. So almost every anesthesia practice in the country, if you're one of the few that doesn't get financial support from your facility right now, God bless you.
Exactly.
And you will.
It's coming your way because it is for about 85% of practices out there where in those facility-based financial support agreements, a lot of facilities want to see, like, well, what am I getting for this? Well, you're obviously getting anesthesia services for all your different procedures and stuff, but they want, like, a little bit more. They want proof that I'm getting a really good quality, the value part of it, right? And so we're working on trying to advise anesthesia practices on there's ones that demonstrate value, there's ones that you're kind of stubbing your toe if you're putting them in your contracts, and so there's other sorts of areas we want to try and advise our ASA membership on. This is a good way to go about that sort of conversation about the value.
I love the acronym CAPE. It reminds me of Superman.
To the rescue.
Yeah,
here we
exactly.
Yeah. Well, I know it's wonderful to hear the advocacy that's going on behalf of anesthesiologists. You said we can go to the website, learn more information. Are there newsletters or anything else that kind of goes out or information that you can put on a regular basis?
Yeah. We try and post things that we think will be of interest to the ASA membership in general. We have a whole library of timely topics where things come up, and we post short, digestible articles there on the website. But we also and we put things in the Monday morning update and things like that.
To say the scenes.
But we don't have an independent newsletter. We're respectful of people's.
That's a lot of work.
Yes. Well, and it's also it's the bandwidth that people have to absorb incoming information is pretty narrow, and so we try and limit our communications to the established channels. But then when there's something really important, get it out there.
Yeah.
I will deliberately try and drive some internet traffic though. So the timely topics, such as the one I was talking about before, how there's the difference in the 10 cents between the two different types of conversion factors. We've got a well-written timely topic from our Committee on Economics APM work group describing how that works out and everything. We write plenty of ASA monitor. I think we did 2 or 3 ASA monitor articles.
Some articles in the monitors,
We've got one coming out in the November monitor about the annual commercial conversion factor survey. If you want to learn a little bit more about the whole MIPS process, I just published an article this month in Anesthesiology, which is our flagship journal for the ASA, about anesthesia clinician provider performance in the first 5 years of MIPS and how that's gone. And we actually do a nice little focus on some simple math there about how the bonus payments for the average case is about 12 units. The average Medicare conversion factor is about $20. So you can get about $240 per Medicare fee-for-service case. But the bonus payments max out at around 2%. So for every one of those cases, you could potentially get an extra $4 for doing that. And over the course of the year, depending on how many Medicare patients you take care of, it's roughly somewhere around like $950 where you would actually get back in bonus payments if you were had perfect scores in the MIPS performance. CMS themselves says that the cost of reporting to MIPS is actually more than $1,000.
Yes.
So it is literally a lose-lose when it comes to just basic economics for your practice. So if you want to learn a little bit more about that, let's get some clickbait there too.
Yeah, that's great. Yeah, please be sure to check that out. If there are any early career, no matter where you're in your career, you feel like you want to advocate to support the ASA, they can reach out to your committee.
Absolutely, yeah.
Yeah, that's great. All right. Gentlemen, thank you so much for joining us on Top Med Talk.
Thank you
It's always
both,
great to hear this story.
Thank you very much. Anytime we can find anybody that wants to talk about economics for 30 minutes, we'll take it.
We could go much longer.
You got another hour? What are you doing right now?
You know what? You guys did a good job of making us not get too depressed about it.
We tried to keep it a little bit higher.
Everyone else but us is getting the money here. The payers are certainly holding on to it, but we're trying to come up with ways for the practice to get it.
Well, you are appreciated.
Absolutely. Thank you for all the work and advocacy that you guys do. We know it's a lot of time and energy, so thank you. And thank you for listening to Top Med Talk. You can always find us at topmedtalk.com. We're on your favorite social media platform. We're on YouTube. If you see us there or on your podcatcher, give us a thumbs up, give us a 5-star rating. Let us know what you think. Let us know what you want to hear more about. If you want to hear more about advocacy, please do check out the ASA website. Thanks, everyone. Oh, and thank you to the American Society of Anesthesiologists.
Can't forget them.
Yes. Thank you so much. Thanks for listening. Cheers, everyone.
Bye.
Thank you.
Bye-bye.